Gastrointestinal bowel function. Bowel incontinence is usually related to anal sphincter dysfunction due to anal surgery, childbirth trauma, Crohn's disease, or diabetic neuropathy. It's less common than urinary incontinence. It is believed to affect 20% of the community of older persons and 50% of the long-term care residents. Bowel incontinence is usually related to, as I said, the anal sphincter dysfunction due to anal surgery, childbirth trauma, Crohn's disease, or diabetic neuropathy. And it can also be related to decreased muscle strength due to aging. Temporary bowel incontinence may occur with diarrhea or fecal impaction, however. The muscles of the pelvic floor and the external sphincter are under voluntary control, and the bowel has its own nerve network that stimulates peristalsis when it's distended. So CNS and spinal cord injuries do not affect bowel function control as much as it does the bladder control. The fecal mass enters the rectum by mass movement. The feces in the rectum creates a desire to defecate, and defecation will occur when the anal sphincter relaxes and the rectum contracts. There is an increased abdominal pressure from coughing, sneezing, or tightening of the diaphragm and abdominal muscles to help promote evacuation of the bowel. If defecation does not occur soon after this pressure is felt, the sensation of needing to defecate will soon fade and constipation might occur. This is a list of diagnostic tests and procedures that may be done to help determine why there is bowel incontinence. If a patient is prone to impaction, enemas might be required to help stimulate the bowel to empty. An adhesive pouch can also be placed for patients who have frequent stools, but it's more practical for the unambulatory patients. And we also have to realize that adhesives can irritate the skin. An alternative to the pouch is the adult incontinent brief, or for bed patients, the linen protectors. Drug therapy will include laxatives, stool softeners, bulk agents, and antidiarrheal drugs. Surgical treatment can include repair of the anal muscle, implantation of electrodes that will help stimulate and strengthen muscles, sacral modulation, and placement of an artificial sphincter. Biofeedback has been effective for many patients, but it has not proved useful for patients that have fecal incontinence associated with diabetes, spinal cord injury, rectal trauma, or radiation injury. Dietary changes that might be recommended would be to avoid foods that cause relaxation of the anal sphincter. These can be raw fruits, fruit juices, raw vegetables, sweets, alcohol, and spicy foods, as they all stimulate stool production. Bananas, rice, bread, potatoes, cheese, and yogurt, along with oatmeal, oat bran, boiled milk, and pasta, can help thicken the stool. There's 4 different types of bowel incontinence. Overflow incontinence is caused by constipation in which the entire colon is full of feces. Fecal impaction may or may not be present. There is an uncontrolled, frequent passage of small, semi-soft stools. Usually it's related to a long-standing dependence on laxatives or enemas. We treat with laxatives and enemas, however, for 7 to 10 days until the colon is empty. Then we try and get the patient to increase fluids and fiber in the diet. These patients still, however, may require enemas twice a week or daily laxatives to get the bowel to evacuate. Senna or lactulose is the treatments that are preferred for the older adults. With neurogenic incontinence, activity is stimulated through the digestive tract when food enters the stomach. This type of incontinence is usually found in dementia patients. We treat it with scheduled toileting based on the patient's usual defecation schedule. It may require a constipating drug in the morning and a laxative in the evening, however. With symptomatic incontinence, this is the result of colorectal disease. Usually we see it in the form of diarrhea, and it may have blood or mucus in the stool. Treatment will involve identifying and treating the cause, and avoiding or reducing caffeine intake, alcohol, sorbitol, dairy products, and fiber might also be helpful. Anorectal incontinence results from nerve damage that causes the pelvic floor muscles to be weak, and this can also include rectal abnormalities. We treat with pelvic floor exercises and biofeedback. It may also require surgical repair of the anal sphincter. Nursing care of the patient with bowel incontinence. We need to determine the usual bowel habits and patterns of these patients, their current bowel patterns, stool characteristics, and any related symptoms. Terms that are used to describe the consistency of the feces include liquid, watery, pasty, tarry, semi-formed, formed, and hard. Make sure that you determine the patient's use of laxatives or enemas, any history of childbirth injuries, or neurological conditions that may be affecting their control. Determine whether the patient has the mobility and dexterity to manage toileting independently. Ask if the patient has traveled outside the country recently. There's always the risk of parasites with travel outside of the country. Inspect and palpate the abdomen following auscultation. Monitor stool frequency and characteristics along with skin condition. Encourage adequate fluid and fiber intake and ambulation, and instruct the patient on how to perform pelvic floor exercises. Indications and preparation for ostomy surgery. Well, you need to know what an ostomy is, and this is an artificial opening into a body cavity. The opening on the skin itself is called the stoma. There are temporary ostomies, which may be indicated after surgery or trauma when there's severe inflammation or infection. It usually bypasses the affected portion of the bowel or urinary tract and gives it time to heal. The permanent ostomy is usually necessitated by cancer of the bladder or colon or severe inflammatory bowel disease. Ostomies are covered by an external appliance that are used to collect drainage. The exact placement of the stoma is really important. Two factors have to be considered. We need secure pouch placement and ease of self-care. It shouldn't be too close to the umbilicus, bony prominences, scars, skin folds, or creases in the skin. Fecal matter will be collected from an ostomy in an appliance that is attached to the abdomen, and that depends on the consistency of the fecal matter depends on the colon location of the ostomy itself. So the closer the ostomy is to the rectum, the more solid the stool is. The further away from the rectum, the more liquid it is. An ostomy can be a single barrel, double barrel, or loop ostomy. With temporary ostomies especially, the ends of the bowel can be reconnected in a procedure that's called reanastomosis. When it's healed, the stoma should be a rose red color, somewhat darker than the color of the oral mucosa. Swelling of the stoma is expected especially after surgery, but then it will begin to shrink over a period of 6 to 8 weeks. The ileostomy, we also expect a small amount of bleeding around the base of a new stoma. That's really not unusual at all. An ileostomy is an opening that's in the actual ileum itself, or the distal portion of the small intestine. Excuse me. It's used when the entire colon must be bypassed. For example, with congenital defects, cancer, inflammatory bowel disease, bowel trauma, or familial conditions like multiple, uh, multiple polyposis or many polyps in the colon. The incontinent ileostomy will require the external appliance to collect drainage. The continent ileostomy, also known as the Koch pouch or Barnett continent internal reservoir, creates a reservoir for the stool so it can be drained at intervals from a stoma with a tube. The ileal pouch anal anastomosis creates a new rectum that will allow for nearly normal bowel evacuation. Complications of the IPAA are small bowel obstruction, leaking of the suture lines leading to peritonitis, and inflammation of the reservoir itself. A colostomy is an opening in the colon through which fecal matter is eliminated. A Hartmann pouch will be created by closing the distal bowel and leaving it in place instead of removing it. Sometimes the surgeon does elect to remove it though. These patients will continue to pass mucus through the rectum. The main long-term complications of the colostomy are prolapse and stenosis of the stoma itself, poor blood supply to the stoma, and peristomal hernia. Now, some patients with ostomies will require irrigation. They may have a sigmoid or the descending colostomy. These stools are drier, they're not as liquid, so they just require irrigations every 1 to 2 days to help maintain regular controlled elimination. To do this, you would remove the old pouch and apply the irrigating sleeve. Pour 500 to 1,000 mL of a lukewarm irrigating solution into an enema container and make sure you clear the air from the tubing. Lubricate the tubing and insert it gently into the stoma 2 to 4 inches, or if it is a cone-tipped catheter, 1 inch. Allow the solution to infuse slowly, and if there's cramping, slow the infusion rate. When elimination is complete, remove, wash, and dry the sleeve and apply the external device. Patient teaching topics are going to include stoma and skin care, appliances, irrigation, bathing, diet, fluid intake, sexual activity, resources, and travel.